Yes, yes, I know he won the. Yes, yes. Okay, so good afternoon, everybody. So I think this is, at the moment, we are not live from the Zoom link, but we'll be joining soon on the live session. So in the initial part, we will be discussing the questions which were taken up. So around from 4:30 to around 5 o'clock, we'll be discussing about the quiz questions. Then we will have the basic quiz for around 5 to 5:45, and then the advanced quiz. So we'll be starting one by one from that perspective. In the interim, I'd like to welcome all of you. Dr. Samvar is there, Dr. Manoj, Dr. Shubha, Dr. Rajiv, Dr. Aniket. I'll request all of you to keep your settings at mute. And while the quiz is active, you activate your mic. And at that point of time, you can have the videos as well. So first, we'll be discussing the questions as well. We've got many participants on our on-site session also who are here. So they are also there. So we are now going to start the webinar live from that. I'll request all of you to kindly have mute the mic so that we don't have any confusions in between, and I'll ask questions and we'll discuss about all the details subsequently from that regards. So welcome all of you for this quiz, which is a biennial, which is the annual program which we conduct at MedEClasses. This is the second version. And we got participants from across the globe, from around 20 countries who participated both for basic and advanced one. And so before we go ahead with those, we want to discuss a few questions and a lot of those scenarios because there were some confusions also in that regard. So we will start on that. We are also joined by some of our participants here. We have got Dr. Savar Agarwal, who is there, Dr. Shubha, Dr. Aniket, Dr. Rajiv. We'll introduce them in much detail when we start the quizzes from that regards. So before we go ahead in that perspective, we will go through a bit with regards to the different aspects of the quiz that we conducted. And we'll take feedbacks also from people. And this is going to be a lot of audience participation, which is there for audience who are here also. And the audience who are also joining us from different parts of the world will also participate in the audience questions which are there. So before we start, you all can go look at our website, learning.growsociety.in, which provides a lot of information about pediatric endocrinology, various aspects and practical tools as well. We've got specific training programs in the form of fellowship and diploma programs. We have got a lot of our webinars which happen, including the postgraduate lecture series and the other scenarios which are discussed. Our publications are there and the mobile applications are there in that regard. So MedEClasses quiz, basically we had got two sections we did this time, both for basic as well as advanced. The basic one was mainly for postgraduates and pediatricians, while the advanced was more for people who are doing DM or they're doing fellowship or they are pediatric endocrinologists. And we had got wide participation, as I discussed, from across the globe in that regard. So we'll go through questions one by one, and then we will decide about just to go through quickly. And if there is any doubt, we can clarify from there. So the first, this is for the basic quiz. The first question was a 2-year-old girl with breast development, and there was a hypothalamic hematoma, which was seen in that MRI imaging. So this was a clear-cut answer that we should start for GnRH analog. Now, we see a lot of people talking about neurosurgical review. One message, never refer to a neurosurgeon a hypothalamic hematoma because they will definitely take it off for surgery. So the trick here was to identify the hypothalamic hematoma, and that was the thing in that regard. The second question was a 15-year-old boy with delayed puberty. Now, which of these are basically against the diagnosis of CDGP or self-limited delayed puberty? So clearly, if you are having a bone age which is delayed, height which is within the normal, slightly delayed, no pubarchy, these are all features of CDGP. But if your TV is very, very small, it doesn't favor, it doesn't exclude, but it doesn't favor also CDGP in that regard. So that was the question here. Next question. So a lot of people talk about questions being lengthier. So I think next time we'll give more time. Even for our assessments, people tend to say that they are very lengthy questions on that. So this was basically a very interesting case in which you had an ovarian cyst, which was associated with precocious puberty. Now, when we have an ovarian cyst with precocious puberty, the main question was, what do you do? Now, we usually say you exclude hypothyroidism, you exclude McCune-Albright syndrome. Then you look at the ovarian size and we talk about observation. But this child had a 4 centimeter cyst with cyst within cyst appearance. So this is a bad prognostic marker that you need to do a surgical intervention. So most people talked about tamoxifen. Now, tamoxifen is basically recommended only in scenarios like McCune-Albright syndrome, as you had seen that case, Dr. Priyanka. So in those scenarios, we can use it. Otherwise, it's not required for routine ovarian cyst. The management largely will be surgical management, which will be recommended from that perspective. This case was basically, again, a very simple question. It basically asked that if you have gynecomastia, which of this is not a marker of pathological cause of gynecomastia? So a lot of people said that if the onset is at the time of puberty, this is basically suggestive of a pathological, which is clearly not, because that is a normal physiological variation. Tenderness is clearly not a basically presentation which is there in that perspective. Now, this is a bit of a complicated case, but this essentially is a case of hypokalemic alkalosis, failure to thrive, polyuria, and there is a normal blood pressure. So what will be the next test you want to do? The most likely diagnosis here will be Bartter syndrome. So the question was basically hypercalciuria. So a lot of people got it right in that regards. The next case was interesting. Hyponatremia with SIADH. Yeah. Manoj. So hyponatremia with SIADH, the girl had presented with abdominal pain. So whenever you diagnose SIADH, you have to start considering the alternate possibilities as well. So hyponatremia, SIADH, abdominal pain, diagnosis porphyria. So urine porphobilinogen, again, a lot of people got it right. So this was pretty straightforward. Now this was the bone age. So we had given a bone age and asked what is the bone age. So we can see this is the one in which there was a maximum split. So some people said 9 to 10, 11 to 12. So we hopefully with the bone age session would have helped out on that perspective. So this is of course a bone age was there. Now this is basically again indications for evaluation of growth hormone deficiency. So when do we evaluate for growth hormone deficiency? The classic indication is a child who is very short and not growing at all. So what we're saying, fall in height SDS by more than 0.5 in 2 years is very limited. So we say crossing of 2 or more percentile lines over 2 to this thing, 0.5 over 2 years is very less. Otherwise, all work very clearly suggestive of a need for growth hormone evaluation. Next case was, I think this was easy. We saw the case today also, an obese child who presented, who was normal initially, then had hypotonia, then had developed hyperphagia. So this was classically Prader-Willi. The treatment option, a lot of people talked about leptin because there was no features of leptin here. Of course, this was classically a Prader-Willi syndrome. There was feeding difficulty in infancy, hypotonia, so Prader-Willi and growth hormone. So that's why we gave somatropin will be the answer here. Now, this was again a case which was basically a 14.5-year-old boy who presented to us with marginally low growth hormone. So we always talk about this, that if you have done a non-stimulated, non-primed growth hormone level, you will not be able to identify growth hormone deficiency. The GH is only 6. So this is a very, very marginal case. And height is also not very short. So best would be to start testosterone, because this boy is already 14.5. If he was less than 14, I would say, okay, observation for 6-month period will be something we can consider. But this case, you definitely would require a therapy in terms of growth testosterone in that regards. Now, this was again an interesting question, a question of a boy with obesity. And what we were seeing here is that in obesity, you had got a low level of growth hormone and a higher level of IGF-1. So we know obesity is a growth hormone sensitive state. And what was the explanation? So why do you think this is wrong, Dr. Vibha? The fourth one, reduce IGF. What happens to IGF-BP production in obesity? IGF-BP becomes less. So free IGF-1 level becomes more. So that's why you have got a low growth hormone and a high IGF-1. So obesity is a growth hormone sensitive state. Malnutrition is a growth hormone resistant state. High growth hormone, low IGF-1. So this was a slightly tricky question, but then a lot of people got it right. Now this was again hyponatremia management. So this is something from a standard protocol as to how much fluid you want to give for 122. So basically it said that you don't give too much normal saline and then you try to build it up gradually after the initial rise. The next question was about free water deficit. How do you estimate free water deficit, Dr. Kamlesh? Yes. So that is one way, and the other is pour into the sodium and the body weight. So this was a simple formula. Again, few people got it right. So again, this is more of an equation based upon this. Then next was interesting. This was a case scenario of hyponatremia who was admitted in the hospital, whether this is SIADH or some other form which is there. So the question was, all of these suggest SIADH except. So low urine output, of course, suggests SIADH. A urinary osmolality which is high will suggest SIADH. What should be the urine osmolality in hyponatremia, Dr. Manoj? Less than 100. So if it's more than 100, it means that you have got a dilute serum, but you have got a concentrated blood. So this is again favoring SIADH. Dehydration, of course, is a part of SIADH. You don't have dehydration. That's a exclusion criteria. And uric acid level, this is very important. And I always say that if your uric acid is high, it means you are hypovolemic, and that excludes SIADH. So that was the pointer which was against SIADH in this scenario. Next case was a thyroid swelling, and you had got somebody who had got features of thyrotoxicosis. So you had got a high FT4, low TSH, and you had got a solitary thyroid nodule. What will you do, Dhwani, in this case? Yeah, so imaging shows that there is a toxic nodule. Then? No, it's a toxic nodule, so FNAC will not be of much help. So option is surgery versus radiation. Now, surgery is preferred in children because of the risk of malignancy. If you give them radioactive iodine, it will have a low dose radiation to the remaining gland. So that's why surgery was the right option. Definitely, you will not observe in this scenario. You have to do treatment in that perspective. Now, this was basically an early discharge, and that's why the TSH level was 36. So again, you should repeat it. So this was within the first 48 hours, and we say that you should repeat it after 7 days. And the TSH level was borderline in that perspective. Now, this was a 12-year-old girl who was referred with scenario of hypocalcemia, hyperphosphatemia, and your hypophosphatemia and PTH was on the higher side, and vitamin D level was low. Now, what will be the way to go forward in this scenario? What do you think? So most likely this will be a secondary phenomena rather than a primary phenomena. So best would be to give a course of vitamin D and look at the PTH. Typically after 6 to 8 weeks is when you should look at in that perspective. 10-year-old girl with bony deformities and pathological fractures. So this was an interesting scenario, and she had got severe metabolic acidosis. So if you have metabolic acidosis with fractures, you're looking mainly with which RTA? Usually distal RTA. And what was shown was she had generalized amino acid urea. Amino acid urea means Fanconi, means proximal RTA. So this was a confusing question, whether it is a proximal or a distal RTA. So how do you differentiate those? Dr. Santosh, what do you think is primary here? Yes. So hyperparathyroidism causing tubular dysfunction, causing Fanconi. So this is actually a scenario of more of a secondary cause rather than a primary cause. And this is primarily a distal RTA, and hyperparathyroidism is causing that. So these were a bit of a tricky questions, but if you had applied your mind, you could make those answers well in that perspective. Now this case, So 5-day-old girl with diabetes. Now the question was, what are the indicators of neonatal diabetes and the criteria? Now, which is unreliable, Dr. Pradeep? So, yeah. So HbA1c is falsely low in the neonatal period. That is why we do not talk about HbA1c being a criteria here. And that was clearly there. I think this was there in glucose module as well in that regard. Now, this boy born to a mother with diabetes. Now, this was an error. I think this we changed later on because this should have been 25 and above. So this was supposed to be 32. So both of these were right actually. So we nulled these questions later on and this was an error. So this was part of the printing mistake or something. So we know that there are specific operational thresholds which are there for different age groups. So Manoj, what are the operational thresholds? And what is that for 4 hours, 24 hours?
For the 4 hours, it is 25. For the after that, 35, 48, and 50.
Yes. So this should have been 32 actually, and then it would have been right in that regard. Next question, again, basically talks about a corrected potassium. So this was again a calculated question that for every 0.1 decline in pH, how much does the potassium go up, Vibha? 0.6. So this was a calculation picture. So 2.6 was the right fit. So you can take 7.3 or 7.4. So we had taken here, I think, 7.4 because 6.9 was there. So 0.5 decline into 5, 3. So this becomes like actual from 5.6, it comes down to 2.6. Next question was, again, this is a very, very important question. In fact, we had a case exactly like this admitted today with very severe metabolic acidosis, 0 bicarbonate and other parameters. The most important thing to prevent rhabdomyolysis. Now, what happened in this case was presented is that he developed rhabdomyolysis later on in renal failure. So how could we have prevented that? By giving phosphorus right at the beginning. So that is why if you have very severe decay, or ideally any decay, you can use potassium phosphate half. It doesn't make a difference. But if you have a cost issue, everybody who has got a very severe decay start right in the beginning. So this is something which could be prevented from that perspective. Now, this was again a case which we have discussed. This is very important from a clinical perspective about TSH levels being falsely suppressed in an intensive care setting. So which of these do not? Dr. Seema? So dopamine, basically dopamine definitely can. Hydrocortisone does, shock can, so dopamine. So this was like a question just for the ICU sort of a setting in that regards. Now, 3-week-old boy again referred for prolonged unconjugated hyperbilirubinemia. And what it was saying is that initially the thyroid level was normal. And now the thyroid level was showing that there was a false negative screen. So what are the causes of false negative screen? Delayed test, twin-to-twin transfusion, non-thyroidal illness, all can cause. Hyperbilirubinemia does not. So this was a simple question from that perspective. A lot of people got it right. Now, this is for the basic quiz. So we haven't gone to advanced one. So advanced were really advanced. So that is, so the typical. So this was question 25. This was a case of congenital hypothyroidism. And we were asking, what are the predictors of a permanent hypothyroidism? So, Dr. Vibha, what do you think?
Initial TSH, and when the requirement decreases by 2.5 or 3 milliliter, this is true, and the need for increased thyroxine, this is absence of lower indole receptor, this is doesn't make.
It doesn't mean that it will be a permanent or a transient one. So this was an important question. I think we discussed this also in the thyroid session as well. So very commonly in that perspective. This again was a case of hypernatremia. How do we manage hypernatremia? We'll be discussing much more in detail subsequently. So again, don't be too aggressive. It was more like a half normal saline over that period of time. That's what we talked about. So usually if you talk about around 120% maintenance, half normal saline, you're pretty much okay. So this was from that perspective. The next case was basically this again. I think there was a controversy there about a case of rickets in which we gave treatment, and there was a concern whether what will be a case of non-responsiveness. So we said that no line of healing. So Dr. Savar, I think, is there. Dr. Savar?
Yes.
Yeah, Dr. Savar. So you were thinking that probably 12 weeks would have been a better option in that perspective.
That's what I thought.
Yeah. So yes, but currently we talk about 3-month treatment. Earlier 6 to 8 weeks was considered. So when we talk about line of healing, it should usually appear by 6 to 8 weeks. But I agree, if you go strictly by protocol, it will be 12 weeks. Other message was that if your ALP levels increase or there is a bone pain or phosphorus increases, that is not a marker of a lack of response on that. But I think your point was well taken from that perspective. I think you had a point on the glucose levels also, which I think was the error, which we rectified subsequently on that. Yeah. So we are having 5-10 minutes more to discuss. So we will try to finish off this basic one, and then we'll go forward from there. So this is again an important question. A 2-month-old boy presenting with hypocalcemic seizure, and he had low calcium, low phosphorus, high PTH, and low vitamin D. Now, a very common hypocalcemic seizure presenting to us in the IPD. He was managed with intravenous calcium. Now, what do we do? Here again, unfortunately, what we are seeing, most people are not giving a short course of calcitriol. And this is why there is a recurrence of hypocalcemia happening. We had the typical case who was discharged. Next day, again, becoming tetany and seizures and everything. So why we are giving this short course of calcitriol basically is to ensure that his level build up. Because vitamin D has got a long half-life. By the time the vitamin D level build up, it will take a long time and you will not have a good response in that. That's why we have to give this cholecalciferol in that perspective. Now, next scenario, a 14-year-old boy who presented basically with a scenario of rickets with hypophosphatemia and a normal PTH. So this classically is a hypophosphatemic ricket. So we just wanted what is the inheritance. It is a X-linked dominant. So I think this was the last question. And again, this was about a case of unilateral undescended testis. So you had a unilateral undescended testis. The other testis was enlarged. There were no other features of abnormalities. What to do? Now, many people talk about observation. I think that is something which is very important. It may be an abdominal testis. You have to do a laparoscopic exploration. That is very important. MRI is not going to help you a lot. AMH and inhibin, Dr. Kamlesh, do you think it will have a role? So one testis is there, you will not have any benefit from that. So these were the basic questions. So I think we'll see if we have time, because advanced are more advanced and people are getting a bit concerned about the advanced one. I think we have got 4 minutes. So we will probably start maybe a couple of questions on the advanced quiz before we start with the quiz. Meanwhile, we'll just check about the people who have joined us.
Dr. Anurag, this question talks of a small swelling on the left side.
Yeah.
What was that?
So that swelling was not testis. It was, so even if you find what is known as a Nubin, and even if you have an enlarged testis on the right side, the American Urology Association, it still says that you have to do an exploration unless you are sure that this is a testis. So presence of a Nubin-like structure, which you can say it is an atrophic testis and an enlarged contralateral, still you have to go ahead with laparoscopic, because you may miss an intra-abdominal scenario. This is an important perspective. That's what we thought. We'll keep this as a message on that. So I think key points here would be this case and the calcitriol, because that is something which can save a lot of hypocalcemia from happening on multiple times in that perspective. We'll take a couple. We have got maybe 3-4 minutes. We'll take a couple of advanced questions before we move ahead with the quiz directly. So we had this case who presented to us with on and off facial swelling, had obesity, features of Cushing syndrome, and we can see that there was a persistently high cortisol level. ACTH was low. So this was a ACTH independent Cushing syndrome, and CT showed normal adrenal gland. So diagnosis, PPNAD, most likely Carney's complex. So it wanted to know what are the associations of Carney's complex. So medullary carcinoma is not. So these are like usually more evolved questions, but normally they are associative questions from that perspective. Now, this is an important management issue. A child with histiocytosis going for chemotherapy already has DDAVP. What do you do? If you give them a lot of fluid, they will go into fluid overload. So best would be to give a low dose vasopressin infusion. That will be able to help out in that regards. 6-year-old girl with a vaginal bleeding. So this was basically a von Wijk-Grumbach syndrome. The question is, why did she not have a pubic hair development? So what are the main reasons, honey? So why do von Wijk-Grumbach not develop pubic hairs? Because they have delayed bone age, they have got other things. But what is very important? Their prolactin is high. So yeah, so TRH is high, prolactin is high, prolactin suppresses theca cells. So they don't have a TSH effect on adrenal production. So that's why adenarche. So classically, a lot of breast development, no pubic hair and bleeding. That is what is the discrepancy of von Wijk. I think this will be the last case we will take. Again, a case of dehydration, hyponatremia, hyperkalemia, metabolic acidosis, pseudo-hypoaldosteronism. So you first do a renal ultrasound to identify that. Okay, so aldosterone is low. So this was an error that way. So it was supposed to be a high aldosterone. So that so this question we have to think of. So I think we will close on that because we are touching at around 5 o'clock. We'll now be starting our basic quiz first, and hopefully all the people have joined out from that perspective. So you've got all the scoring sheets ready as well. So now I think the time has come to start off with our further session, which will basically be the basic quiz. So I'll request all the finalists to come up there. We have already joined by Dr. Sawar Agarwal, Dr. Rajiv Das, Dr. Jaya Pandey, Dr. Azad Halim, Dr. Shubha Srivastav, and Dr. Saddam was also there. So I'll request one by one to people to kindly introduce them. So I'll start off with Dr. Sawar. Dr. Sawar is a legendary figure in pediatrics, especially in the Chhattisgarh region, and he has been involved in practice now for many years. And last time also, he was part of our quiz. So Dr. Sawar, can you please introduce yourself?
I think you have already said most of the things. I am a generalist, a postgraduate from PGI Chandigarh in 1980, and have been in practice for almost 40 years now. And I have a keen interest in endocrinology.
And you did very well in the quiz, and we were in a dilemma whether we should include you or not. And there was a lot of debate on that, but finally we said, no, we should definitely go ahead. And so you were part of it. Then we are joined by Dr. Shubha Srivastav, who is a pediatrician from Lucknow. Dr. Shubha, kindly introduce yourself. You have to unmute, I think. Yeah.
Hello, I am Dr. Shubha Srivastav. I have done my MD Pediatrics in 1992 from GSVM Medical College, so a long time back. Now I am again in the student wing. I am very happy to be here. And I did the railway service for 26 years. Then I took VRS last year and started practice in Lucknow as a general pediatrician.
Thank you, Dr. Shubha. And Dr. Rajiv Das is with us. He is from Bardhaman Medical College in Bengal. So Dr. Rajiv, please introduce yourself.
Sir, I am Dr. Rajiv Das. I am Assistant Professor in Pediatrics in Bardhaman Medical College. I did my MD in NRS Medical College. And now I am acting as a faculty in Bardhaman Medical College. And I am very much privileged to be here with you to take part in this quiz.
Thank you, Dr. Rajiv. We've got Dr. Jaya Pandey, who is with us. Dr. Jaya is a faculty at Regency Hospital, particularly in the intensive care field. Dr. Jaya, kindly introduce yourself.
Good evening, everyone. I am Dr. Jaya Pandey. I have done my DNB Pediatrics from Madurai and SRship from PGI Chandigarh, and presently I am practicing at Kanpur as a pediatrician.
Thank you. We've got Dr. Azad, who is from Iraq. He is from Duhok University, very enthusiastic, and he has come all the way from Iraq for this course. And welcome, Dr. Azad. And
Thank
please share your experiences as well. Yeah.
Thank you very much. So I'm Dr. Azad Halim. I'm Assistant Professor of Pediatric, Head of Pediatric Department at University of the College of Medicine. I'm practicing pediatric endocrinology. I'm more than 21 with you, Dr. Anurag. I'm very happy to be with you today. Really, I enjoy all the cases.
Thank you. So we are waiting for Dr. Saddam, who is not yet joined. He is from Lahore. I don't think he's here. He is from Gangaram Hospital. So as and when we will have a look at it when he is going to join. So we have got Dr. Saddam is not there. So we'll start off with the 5 people, and we have got 2 scorers with us, Dr. Vibha and Dr. Dhwani, who will be scoring the sessions. So we'll start off the quiz right away without wasting any further time. And I'll request all the audience who are there to kindly not speak out before, because that will give them a clue and that will be cause a bit of a issue on that. And we also have audience rounds which are there. Basically, at each round end, we will have 1 question for the audience which are available from there. So Dr. Bhatti has joined in, I think. Yeah. No, he is for the advanced. So this is going to be the basic quiz. So we'll start off with that. So before we start, we will talk a bit about the finalists. So we have got Dr. Savar Agarwal from Ekta Hospital, Raipur. We've got Dr. Shubha Srivastava from Harbilas Hospital, Lucknow. Dr. Rajib from Vardhaman. Dr. Saad somehow has not joined yet. So we'll see if he joins on that. Dr. Azad from Iraq and Dr. Jaya from Regency. These are the 6 people who are there in terms of the program. So the first, so this is one which is going to be part of this program. The first prize would be the subscription to the entire basic pediatric endocrine course. The second prize will be a subscription to the adolescent endocrinology course. And then we have got all others will get a complimentary growth course subscription as part of the finalist round from that perspective. And there are audience rounds. So we will encourage all the audience to write on the chat option here to get the answers, and we'll ask the audience here last once we get all the answers, because otherwise there will be a confusion from there. But this is definitely, I'm sure many questions will come to the audience here as well. So the rules are there are 4 direct and 1 buzzer round. We'll talk about how the buzzers will work out. 10 marks for a direct and 5 for a pass. So that will be there. 15 seconds to answer, and only 1 answer is acceptable. So whatever you say, don't change your answers, because then we won't accept it and you will help the other person in that regards. Quiz master's decision will of course be the final. So there will be no debate here, and whatever the answer is, we will have the answer from that perspective. So I think we will start off with the first round, and probably we will be better off if we have the you can switch off the. Okay, so we will start off. No, start. Keep the data. So we'll start off with Dr. Shubha as the first. Dr. Rajib will be second. Dr. Jaya will be third. Dr. Azad will be fourth, and Dr. Savar will be the 5th person. We don't have Dr. Saddam yet, so we will go in that direction, and then we will go in the reverse action. So the first round is labeled as make the diagnosis. So I think you will be able to see the screen, everybody. Are you able to see all the participants?
Yes.
Yeah. So we'll start off with the first question, and this is for Dr. Shubha.
Do I have to reply by?
No, you have to speak. You have to speak. So this is a 2-year-old girl with precocious puberty, and this is the MRI finding which is there. Now, the question is very simple. Which point on history would clinch the diagnosis? You will ask one question on history, and you will know what the diagnosis is. So Dr. Shubha.
Seizures.
What type of seizures?
Elastic seizures.
Gelastic seizures. So exactly. So this is the right answer. So 10 points. This is a hypothalamic hematoma and clearly the elastic seizure. So 10 points to Dr. Shubha. The next direct question is to Dr. Rajiv. And the question is that we have a 1-year-old boy with failure to thrive in polyuria. The weight is less, length is less. He has got hypertension. There is metabolic alkalosis and hypokalemia. So hypokalemic alkalosis is hypertension. So now I think you can think from that perspective. ACTH is normal. Cortisol level is normal. Renin and aldosterone both are low. So we have got hypokalemic alkalosis, endocrine hypertension. The question is, there is no response to aldactone. So I think now the question is, what is the diagnosis? So Dr. Rajiv, what is the diagnosis? Which channel defect? I want the specific channel defect.
Sir, it is a case of apparent mineralocorticoid excess.
Apparent mineralocorticoid excess.
No response. No response is Little syndrome.
So we are supposed to give one answer.
Yes, sir. Yes, sir. It is Little syndrome. No response, it is Little syndrome.
So it is Little syndrome. So you should think before you answer. So it's Little syndrome. Which is the defect in the, which molecule is the defective part in here? Which channel? So it is Little syndrome and the defect is basically in the ENaC channel. So I think we'll give the full questions because he thought a bit early on that. So I think the full marks again to Dr. Rajiv. So good performance going on. No questions being passed up. Next question to Dr. Jaya. 2-month-old girl with polyuria. Blood sugar is 430. HbA1c is high. So 2-month-old girl with HbA1c. On initial insulin, the sugars became better, but the child had persistent hypotonia and developmental delay. So this girl has neonatal diabetes with hypotonia and developmental delay. What is the likely molecular defect? So we are talking about making a diagnosis here. Dr. Jaya. So you want to pass the question? Okay, no worries. So we'll pass on to Dr. Azad. Neonatal diabetes with hypotonia.
Yes, we have a sodium chloride channel with a potassium. Both receptor present in the brain and also in the pancreas, islet cell. So I think the defect in the channel.
Sodium or potassium? Which one?
Potassium.
Potassium. So, okay. So we'll give 10 marks on that. This is a case of 5 marks because it's a pass one. So KCNJ11, potassium channel defect, where both the pancreas is not producing insulin and the muscles are not getting the power. This is the Dent syndrome. Developmental delay, diabetes, and neurological features. The next direct question is to Dr. Savar. So Dr. Azad, sorry. So Dr. Azad, 6-year-old boy with swelling. And you can see the boy who is there. He is looking short and plump. So very, very classical features. Weight gain, growth failure, myopathy. So he's got all the features which are there. The question is, very simply, he also has got stria. So everything is there. My question is, what is your first test you will order?
This is a classical case of the Cushing syndrome mostly.
Yeah.
So we say the ACTH and serum cortisol.
ACTH and serum cortisol at what time?
Morning.
Morning. Would you do a cortisol before before that? Will you give dexamethasone or not?
Yes, this is proven to be dexamethasone suppression test overnight.
So that's what I'm asking. Will you do a morning cortisol or will you do a dexamethasone suppression test?
Dexamethasone suppression test will be diagnostic.
Okay, we'll take the second one. Dr. Savar, what do you think? What will be your first test?
No, morning cortisol is more specific than dexamethasone suppression test.
Okay, so if you tell me, right, why are you doing morning cortisol and not dexamethasone suppression, I'll give you the marks. The answer is you should first do a 8 AM cortisol. But why?
Yes.
My question is this.
Because this is for the further diagnostic tool, the dexamethasone suppression test.
So any condition of Cushing syndrome can have low cortisol.
Yes.
Which?
Low cortisol, sorry.
So Cushing syndrome with low cortisol.
If it is exogenous.
Yes. So that is why you want to do the morning cortisol in the first thing. Then you go ahead with morning cortisol is high. Then you go for evaluation.
Yes.
I think we'll give 10 marks there because we are being lenient, at least in the first round.
Yes.
Second round will not be lenient. So we'll be, next question is to Dr. Savar. 6-year-old girl with early puberty, stage 3 breast, stage 2 pubic hair, and already periods have started. LH level is 2.4. So this looks like a central precocious puberty. Bone age is advanced. You are finding multiple cafe au lait spots. So multiple cafe au lait spots with stage 3 breast development and menarche. What is the likely diagnosis? Think carefully before you answer. There is a catch in it. So you're muted. You're muted, Dr. Savar.
Neurofibromatosis.
Exactly. So this is NF1. And that's why I said you have to have a catch, because this was a scenario in which we had got a cafe au lait spot with high LH. So this is not McCune-Albright. This is basically a neurofibromatosis. So again, 10 marks. So this is the end of the first round. So I think, what is the score here? So loud, you can come here or say louder. So you can speak louder.
So we have Azad sir leading at 15. Everybody else at 10, and Jaya ma'am still waiting to open the account.
Okay. So that is the first round which is there. The next round, we will, before we start the next round, we will have an audience question. So all the audience who are there, please have your fingers ready on the keypad, and you have to answer on the chat option the question. The first one to answer, we will get the information from that perspective. So this is the question, right in the chat option. 8-year-old boy with precocious puberty. Height is 132, so pretty tall. Blood pressure is high. So hypertension with precocious puberty. SPL is 9 centimeters. Pubic hair is stage 4. No palpable gonad. So a boy with no palpable gonad with hypertension. The question is, this is the adrenals. The question is diagnostic test. So write on the chat option. So we will open the chat and see people. The first person to write on the chat option, in a boy who has got precocious puberty, but there is no gonad and there is hypertension. So Dr. Manoj Reddy is already answered. It is deoxycorticosterone. It is 11-hydroxylase deficiency. So I think a big applause to Dr. Reddy. I'll request the quiz participants to kindly not answer. Let other people answer as well, because you will, of course, this will be easier for you. So I think this was a good option to go forward from there. We'll see if there is any other. So DOC again. Okay. So people are also answering in the Q&A. I'll request in the chat. So already Dr. Mosa Kutti has written DOC. So you can write his name. He's from the audience. So big round of applause to Dr. Mosa Kutti. He had written from that perspective. So now we'll move forward to the second round. So round 1 scores we already done. Now the next round is called the plan the test. So you have to plan which test should be done next. So we talked about diagnosis. Now we are talking about the test to be done, and we'll go in a reverse order. We'll start from Dr. Savar Agarwal and we'll go back from Dr. Azad, Dr. Jaya, Dr. Rajib and Dr. Shubha on that. So the first question is, 1-month-old child with atypical genitalia, Dr. Savar, no palpable gonad, no Mullerian structure. So you've got a child who has atypical genitalia, has got no palpable gonad, no Mullerian structure. Testosterone is 100 and LH is 1. So what will be the next test you want to do?
Dihydrotestosterone.
Okay. So what are you thinking of? This is a XY DSD basically. And you are thinking of either a 5-alpha versus a androgen sensitivity. So DHT, either baseline, because LH is pretty high. I would be happy with a baseline DHT as well. Or you can do a stimulated. So perfect answer. So testosterone to DHT ratio, 10 marks to Dr. Savar. I think this was a good answer on that. The next question directly is to Dr. Azad. So Dr. Azad, your question is, 3-year-old boy with failure to thrive, height is less, weight is less, he has got metabolic acidosis. There is metabolic acidosis. There is hypokalemia. So metabolic acidosis with hypokalemia, I have given you the numbers of chloride, which is 114, sodium of 138, bicarb of 12. What test will you do next to identify the further workup?
This is mostly renal tubular acidosis.
Okay, so what test will you do?
For the renal tubular acidosis, we can do 24-hour urine collection or calculate an anion gap. Both of them is, I think, good.
So anion gap is already there, which is a normal anion gap. So you have got a normal anion gap metabolic acidosis with hypokalemia. Dr. Jaya, you have any further thing to add?
We can do urinary anion gap.
Yes, so I think that is
then anion gap. My answer is that.
So yeah, second round will be
electrolyte. Then surely you will do anion gap from the urine.
So second round will be more strict. So this will be urinary anion gap. I think this was a trick question basically. Anion gap you already given. So 5 marks to Dr. Jaya, who gave the answer correctly. The next direct question would be to Dr. Jaya now. The question is 15-year-old boy with delayed puberty. Now we have got a boy with delayed puberty who is tall, has got a low level of testosterone, bone age is delayed, LH is low, there are no neurological features or anosmia. So you've got a boy with delayed puberty. The next test, which test will be appropriate in that regards, Dr. Jaya?
Karyotype.
Karyotype. Okay. Dr. Rajiv?
It is FSH.
FSH. Dr. Shubha? Dr. Shubha? You're muted, yeah.
AMH?
AMH. No. Dr. Savar? No. So we have got a boy with delayed puberty and we have got other parameters which are there. So what will you like to do? So your number will come after this, Dr. Azad. Dr. Savar is first.
We can do the gonadotrophin stimulation test.
Gonadotrophin stimulation test, it may not help much. I'll ask the audience now. You can also answer on Q&A. No, sorry, Dr. Azad is there. Dr. Azad, what is your...
Kalman syndrome.
Kalman syndrome?
Yes.
Okay.
There are no anosmia.
So what will be your test? What will be your test?
A CT scan MRI, I think, will be a good choice.
MRI would be good choice. But yes, we would like to ask some questions as well. Let's see if somebody has given GnRH stimulation test, MRI, pituitary MRI from our audience.
No. Sorry. Sorry.
So this is an important parameter, inhibin B, because inhibin B is a marker which is a very good test to exclude CDGP in this case. Of course, we can think of hypogonadotropic hypogonadism, but beyond this, doing a GnRH test, inhibin B is the best test to identify that. So this was one question which passed everybody. And finally, our audience gave a good response. So I think 3 cheers to our audience who are sitting here, who gave a good response on that. So inhibin B. Next question is going to, I think, Dr. Rajiv. So Dr. Rajiv, your question is 14-year-old girl with polyuria. The girl's height is 156. She is obese. She has hyperglycemia. She has got a high HbA1c. There is acanthosis nigricans. There is a family history of diabetes. So this is a classical diabetes that we are seeing very common. C-peptide is low. Now, which is the most important next test you will like to do, Dr. Rajiv?
Get 65 antibody.
Guarantee. What is? Why?
Because I have to exclude money. It is, though it is a obese, we may not think that it is a case of type 2 diabetes. Before I should exclude type 1 diabetes.
So this is classically looking like type 2 diabetes, but definitely even if you are obese, even if there is a family history, even if there is acanthosis, do a GAD antibody. That is a big message. I think very right answer there, Dr. Rajiv. 10 marks to Dr. Rajiv from that. Next is to Dr. Shubha. We have a 14-year-old boy with on neonatal screening. TSH is 142. FT4 is 2. So you've got clear-cut primary hypothyroidism. Thyroid scan shows no thyroid. Femoral epiphysis is there. What will be the next test which will give you the clue to diagnosis? Dr. Shubha. Primary congenital hypothyroidism, scan showing no tissue. So, Dr. Shubha?
Cortisol.
Cortisol. We'll go to Dr. Sawar.
We can do the thyroid blocking antibodies or the TSH antibodies.
Anything before that? Anything before that?
Ultrasound.
Yes. So the answer will be ultrasound because you have got an absent scan. Doesn't mean that you have absent thyroid. First confirm the ultrasound and then you can go ahead with that. So 5 marks to Dr. Sawar on that. So I think with that we have ended the second round as well. So what is the score, Dr. Vibha?
Now second round we have a Sawar sir with a 25 marks, sorry. 15 Azad sir, 10 marks.
I answer. I have answer.
And 5 marks for Jaya ma'am and Rajiv sir, 20 marks.
Okay, so it's a tough competition which is going on. There are a lot of rounds left. 2 rounds are left. So now, Dr. Azad, you can push forward and we have the buzzer round in which you can score a lot from that regard. So don't worry. For now, we will move towards the next question for the audience. So you can write in the chat or the Q&A, whatever you feel comfortable, because there seems to be an issue with chat, apparently, people are saying. So we'll ask this question is for the audience. The question is 12-year-old girl with growth failure. She is having all these features. You can see brachymetacarpia, webbing, all the features are there. The simple question is the cause of short stature in this girl causes tall stature in which disorder? So the audience can also listen. So be careful. So short stature in Turner syndrome causes tall stature in which disease? I think this is case which has been discussed. Albright's wrong, hypoparathyroidism wrong. Shocks, gain of mutation, no, something else. Specifically, you've got X0. So if you have got more X, Klinefelter. So I think this is because we got 3 wrong. So we will say, so our audience again is saying it will be Klinefelter. So again, this is a Shocks excess because you've got more X chromosome there. So we have already done the round 2. Now we will move towards the round 3, which we will go again from the same order, starting from Dr. Shubha from that. And this is about treatment. So we made the diagnosis, we talked the test, and now the treatment. So 6-year-old girl with altered sensorium, long-standing lethargy and weakness. Sodium was 112. Cortisol was low. ACTH was low. Was given hydrocortisone and 3% saline. And at 14 hours, the sodium is 122. So this is chronic hyponatremia. You have increased the sodium to 122. What should you do here, Dr. Shubha?
Pass the question.
Dr. Rajiv?
Sir, I have to, it is cortisol deficiency. So there is more AVP, so anti-ADH.
So this sodium has gone up by 10 points in 14 hours. You are happy with that? That's a basic question. We'll go back again. Dr. Jaya, from an intensive care perspective. You're muted. You're muted.
It seems to be a rapid correction.
So
she did not come with any seizures or anything. So within 12, within
so what
24
will you do
hours,
now? So what will you do now?
We will come down on 3% saline.
You will come down on 3% saline. You will do something else even further. Okay, we'll come back to you if nobody gives a satisfactory answer. Dr. Azad?
Yes, you give stop 33% saline. We should correct gradually, and we should monitor the patient, and also we should give the patient fluid for the longer duration. So I suppose that give the patient glucose. No, glucose.
What sort of fluid will you give? Which fluid?
Glucose water.
Glucose water, free water. So absolutely right. So this is a very typical scenario that you have got a rapid rise in sodium. You want the sodium levels to lower down. So re-lowering of sodium should be done. And this is done basically either via D5, glucose water, or even sometimes we give desmopressin in that scenario as well. So this was a tricky question, but an important one. If you have a too rapid rise in chronic hyponatremia, you have to re-lower the sodium. That is the question from there. The next question is to Dr. Rajiv. 7-year-old girl with precocious puberty. She has stage 4 breast development, stage 3 pubic hair development, high level of LH, FSH, and estradiol. Ultrasound shows an endometrial thickness of 4.5 mm. Now, she is planned for GnRH analog. Would you like to do something short term? There might be something which else may also be given other than the GnRH analog in this scenario. And you look at the entire picture, look at the ultrasound, look at the LH levels. So would you like to do something else along with GnRH? And that's a short-term treatment. I'm not talking about a long-term treatment here.
Can I give anti-estrogen? Something?
Anti-estrogen. No. Dr. Jaya?
Pass.
Dr. Azad?
Medroxyprogesterone.
Okay, so Dr. Azad is now getting into that realm. 5 marks to Dr. Azad, correct? So you like to give medroxyprogesterone, you can give oral, or you can give a Proginova as well, or in the form of a Depo-Provera as well in that regards. Next question is to Dr. Jaya. Direct question. You have a 2-year-old girl with precocious puberty, stage 3 breast development, and vaginal bleeding. There is low LH, low FSH, high estrogen. There are cafe au lait spots which are there. So this looks like the diagnosis there. The question, however, is a bit twisted. So we don't have a direct question ever. So this is that this girl also has the bony defects. So there are fibrous dysplasias which are also there in this condition. She's complaining of a lot of pain because of these bony swellings and other problems. What will be the most effective therapy for these bony swellings?
Bisphosphonates.
Absolutely. So this is absolutely the correct answer. So McEwen Albright is a somatic mutation in which you will have fibrous dysplasia, cafe au lait spots, precocious puberty. So bisphosphonates will be the right therapy from there. So 10 marks to Dr. Jaya. Now we have Dr. Azad, the direct question to him. The question is, 2-month-old boy with failure to thrive in polyuria. He has got alkalosis, severe hypokalemia, hypercalciuria, and magnesium is normal. BP is also normal. What is the treatment of this case?
So at the first, you should correct potassium because this is life-threatening condition. You should treat potassium.
Yeah, so you should treat potassium, but what would be the specific therapy for this condition? What is your diagnosis? Hypokalemic alkalosis, severe failure to thrive.
Urinary calcium. So this is
high.
Barthel syndrome.
And treatment? Specific treatment?
It will be indomethacin.
Correct.
Yeah.
So absolutely right. So again, 10 points to Dr. Azad again. I think we have the last question in this round directly to Dr. Savar. Basically, we have got a child with seizures and there is hypocalcemia, hyperphosphatemia, PTH is on the higher side and vitamin D is on the lower side. So you've got an infantile child with seizures, forget about the thrive and polyuria seizures, hypocalcemic seizures, low vitamin D, high PTH, high phosphorus, stabilized on IV calcium. I think this is a question which probably was just discussed. So Dr. Savar, do you think we should get another question or you want to answer this one? This we just discussed.
As you wish, as you wish.
So we'll take the second question because there's a similar question we just discussed. So next question we'll take is 13-year-old boy, 45 kg with DKA, pH is 7, bicarbonate is 8, CO2 is 10, blood sugar is 540, potassium is 3.1. All you have to tell me, don't tell me how much fluid is required. You tell me what will be the composition, sodium and potassium for bolus and hydration fluid.
This child will need normal saline bolus and 40 milliequivalent potassium supplement.
40 milliequivalent potassium
per
in the
liter.
bolus fluid. And for the hydration, both I'm asking. So
for the hydration will be 0.45 normal saline.
For the hydration, 0.45 normal saline, and potassium will be
40 milliequivalent potassium. In the bolus, we can give, we can wait for the child to urinate and then we can go on to add potassium. Or at the most, we can use 20 milliequivalent in the initial fluid.
Okay, we'll ask to Dr. Shubha if we have more clarity on that. Dr. Shubha?
Normal saline as bolus.
Yeah.
And 0.45 and as hydration.
And potassium?
Potassium in maintenance fluid, hydration fluid.
Okay. Dr. Rajiv?
Normal saline for maintenance and 20 millimole per liter in the hydration fluid. Bolus fluid. Bolus
40 millimoles in bolus. Dr. Jaya?
No, bolus 20.
Bolus 20 and that 40. So I think you are pretty right. Dr. Savar, I think you gave the same answer at the end?
Yes. Yes.
So I think at the end, Dr. Savar had come to the similar answer. So that is basically you want to give normal saline bolus with 20 millimoles potassium. And in hydration, you can use NS N by 2. I don't have a problem with KCl 40 millimoles. So I think we'll give the marks to Dr. Savar because this was a bit tricky question in that regards. So while the scores are being compiled, we will have the next audience question. You can write in the chat option or as well in the question answer as well. So you can write in Q. So the question is, 3-year-old boy with 21 hydroxylase deficiency on hydrocortisone 25 milligram per meter square per day, high dose, fludrocortisone 0.05, 17 OHP is still high. So he's on a high dose of hydrocortisone and 17 OHP is still high. Which test will improve your management?
PRC.
So we'll ask Q&A, plasma renin. Dr. Subramaniam, absolutely right. So I think that's a good answer. So we'll be keeping the answers. Dr. Subramaniam has got the right one here. So we will announce the audience prize later on as well. So this is the perfect answer. So now we have already finished 3 rounds and the scores. So at the end of 3 rounds, we have got a very interesting situation. Dr. Azad and Dr. Savar are tied at 35 points. Dr. Shubha is at 10, Dr. Jaya is at 15, and Dr. Rajiv is at 20 points. So carry forward from there. We will take the next round, which is the last round, and then we'll have all on the buzzer. So the last round is spot the diagnosis. There will be no pass. So whatever you say, we'll not be passing it up from that perspective. So we will go again in the reverse order. We'll start with Dr. Savar. The question, now this I think is going to be very easy for you. 10-year-old boy with seizures, hypocalcemia, high phosphorus. No more hints. The question is, which parent is likely to also have this disease?
The mother.
Okay, so the diagnosis is?
Pseudohypoparathyroidism.
Pseudohypoparathyroidism, and this is an imprinting disorder, so it has to come from the mother. So 10 points to Dr. Savar. Next question, directly to Dr. Azad. This is a 5-year-old boy with early puberty. You have got a SPL of 8 centimeters and testicular volume of 6 ml. CT adrenal is normal. 17 OHP is normal. HCG is 10. So what is the most likely diagnosis?
So this is HCG, screening tumor. You have to search for the CT scan of the abdomen and the chest.
No, HCG is 10. So normal range would be like up to 10.
Testotoxicosis, the gene study. It's
so
very important.
LHCG receptor defect, testotoxicosis, I think that's right. So again, 10 marks there for Dr. Azad as well. Next question to Dr. Jaya, direct question. 6-year-old boy with hypoglycemia and pigmentation. Now there is hyponatremia, normal potassium, ketotic hypoglycemia, cortisol levels is low for the level of hypoglycemia, and ACTH is high. So this looks like a situation of an adrenal issue. There is feeding difficulty in the child. This is another clue. The question is, which part of the body should you focus your examination first? So you have a child who has pigmentation with hypoglycemia, hyponatremia, and low cortisol, high ACTH. Which body part you like to look at first? And there is feeding difficulty. So that's a big clue.
Abdominal examination.
Abdominal. So we will not have a pass on this one because we said this is not going to pass. This is because sometimes the answer may be spelled out. So anybody in the audience want to answer this one on the Q&A? I. So already Dr. Anirban Ghoshal is saying I. So why are we looking for eyes? AAA syndrome. So this is achalasia cardia, alacrima, and adrenal insufficiency. AAA syndrome. So for that, eye examination for dry eyes would be something you want to look at. So I think this was a good answer from that. Next question is for Dr. Rajiv Das. A 6-year-old girl comes with high sugars on routine checkup. Fasting sugar is 130. 2R value is 145. HbA1c is 6.2. There is a family history which is present. Question is very simple. Which genetic defect are we talking about? Dr. Rajiv. So fasting is high. 2 hours is not very high. HbA1c not very high. Family history of multiple family members with diabetes. Yeah?
GCK defect.
GCK defect. So this is a situation in which body is not sensing your glucose. So levels go up, but they don't go beyond a particular level. So 10 marks to Dr. Rajiv as well from that regard. So GCK defect. I think the final question here to Dr. Shubha. 15-year-old boy with irritability and polyuria. Calcium is 13.8 high. Phosphorus slightly on the higher side. PTH is undetectable. So PTH independent hypercalcemia. Vitamin D is 32, which is normal. Calcitriol is on the higher side. Now you made the diagnosis just by looking at one particular thing on the examination. So you have got hypercalcemia, which is PTH independent, with a level of vitamin D which is normal and calcitriol which is high. What examination finding made the diagnosis, Dr. Shubha? So newborn hypercalcemia, PTH independent.
No idea.
Okay, so Dr. Samar?
The calcium sensing receptor defect.
But why is the PTH undetectable? Dr. Azad? Oh, sorry, there is no pass in this one. There is no pass on this one. So there is no pass on this one. So we will take it from the audience and then we'll come back to you. So audience Q&A. Alopecia. So already Dr. Kompal Paharia has mentioned subcutaneous fat necrosis. So Dr. Vishnu, what is the mechanism here? So
enzyme there that leads to the conversion of
25 to 125. So macrophages have got the 1-alpha hydroxylase action. So Dr. Kompal Paharia has said subcutaneous fat necrosis. So I think that's the perfectly right answer. So with that, we are finishing our direct round. So Dr. Vibha, what are the scores? You can come up and tell the score.
After the completion of 4th round, Dr. Savar and Dr. Azad is still tying up with 45 marks. And on the second position, we have Dr. Rajiv Das with 30 marks. And Dr. Jaya is 15 marks. And Dr. Shubha is on 10 marks.
Okay, so we'll keep it. Yes, so we have got a very, very close fight which is going on. So 35, 35, 20, 15 and 10 and all of that can change in the buzzer round because this is something which can make a huge make and break in that regards. Now, before we go ahead on the buzzer round, did we have the audience round question? Not yet. So for this, we will have the audience question as well. So all of you be ready for the audience question. Write in the chat option. 3-year-old boy with hypoparathyroidism develops abdominal pain, polyuria and vomiting. Calcium becomes 16 and phosphorus is 4.8. Despite decreasing calcitriol, the calcium levels are going up. what is the most likely cause of this scenario? We discussed in this group today morning itself. So anybody can write that this child with hypoparathyroidism, suddenly the calcium requirement is coming down. What is the cause? The audience can write. So dehydration, okay, but why dehydration? Anything else you want to link up? Already the child is hypoparathyroid. So there is a autoimmune. So which other autoimmune disorder can cause something to increase calcium levels? So I think from our side, so cortisol deficiency. So this is development of cortisol deficiency in that perspective. So this is how we will go forward on that. So I think this is the closing part of our different rounds. We will now finally head towards the buzzer round. And the buzzer round is going to be very interesting because we are going to have 10 correct answers and minus 10 for the wrong answer. So anybody can gain 60 points here. So anybody can win from here and anybody can lose from here. Chat to be reset after each question. And I will write an N, which will say this chat has now been reset. The quizzer will write Y. As soon as you say you know the answer, you write Y. The first person who writes Y, I will stop there. I won't ask the question any further. And then you have to answer the question from that perspective. So basically, you have to be very confident and you have to give immediate answer. No thinking time is available in that perspective. So these are the basic rules. So before that, we will try to test it out on that. So I think all the panelists, you can just put Y, all the participants just put a Y there and let's see it's working. So Dr. Sanvar, Dr. Jaya, Dr. Shubha, please put a Y. Dr. Rajiv, in the chat box. Dr. Azad?
I wrote.
No, it didn't come up.
In the
the chat, not the Q&A.
Oh, just a minute. I'm writing, sir. I write 3. My name is Manoj because I'm...
yeah, but Dr. Shubha, now it's coming.
Direct
Let us come as a direct message. Don't send a direct message to everybody.
To everybody.
Just man. It's okay.
And Dr. Rajiv, your answer has also not come?
Yes, excuse me.
Yes. Why is someone telling me not to?
Now come.
Why? Why? This is the chat. Why?
So webinar chat. Dr. Shubha, I've got your message. Dr. Jaya, Dr. Samvar.
Me?
Not yet, Dr. Azad. Wow. And Dr. Rajiv, you are not able to write?
Yes, sir. I am not able to write.
What is that?
I am not able to write.
What's the problem?
Sir, I'm writing Y in chat, but it is not.
So, Dr. Azad, it's come.
Just if you were right.
So what I will do is that at the end of it, I'll write
Y or N.
N. I'll write N, which will basically mean now it's a new one.
Dr. Rajiv may check in the against 2, what is it is showing.
Dr. Rajiv.
Yes, I am sending Y. Okay.
So this should be for everyone. Yeah.
Actually, it changes every time someone writes. It changes. That's why we have to again go to host and panelist. Whoever types in chat, his name comes here too.
Okay.
Like it's come to Dr. Rajiv Das. Now I have to change again to host and panelist.
Okay. So shall we put in the Q&A if you can try that? So we can put in Q&A. So I'll request all the other people to not put on Q&A. No, I think this is not going to work. So chat, I think this is the best option because last time we did on that one. So Dr. Rajiv, are you able to do it?
It's not doing.
Dr. Rajiv Das message is coming to me.
Now it is come.
Yeah.
So I'll write N and then all of you write Y and then we'll start the questions immediately. Yeah. Yeah. Savar, Dr. Jaya, Dr. Shubha, Dr. Rajiv. And Dr. Azad, Dr. Rajiv. Yeah, so we've got all. So I think we all have got tuned to this. So I'll reset it now. You put the Y only when you are ready. And I'll stop the question immediately there. So we'll start off with the first question. 10 marks correct, positive 10, wrong, minus 10.
Gosh.
First question, open to all, on buzzer. 16-year-old girl with irritability. FT4 is high, TSH is low. There is a solitary nodule. What would be the most appropriate treatment? So it's Dr. Azad.
Yes, so while this patient have solitary nodule and TSH is very low, really the most appropriate treatment after stabilization will be surgery.
Okay, so plus 10 to Dr. Azad, correct? So as discussed earlier, we should not go for radioactive iodine in this scenario. So next question is again open to everybody. Now, 3-year-old boy with polyuria, dehydration, urinary osmolality is 50, sodium is 156. Next test. Dr. Savar Agarwal. Dr. Savar?
Yes.
So what test will you do?
AVP.
AVP stimulation. So you will see the response to AVP. So 10 marks to Dr. Savar. Again, so please write why, don't write the answer there.
Yeah, that was a mistake. Yeah.
Okay. So we go for the third question. I've already reset. The third question is 12-year-old girl with multiple fractures, failure to thrive, polyuria myopathy, hypokalemia, phosphorus is low, there is metabolic acidosis, nephrocalcinosis. So other than bicarbonate and potassium, what treatment also will you give to this girl? Dr. Rajiv?
So potassium, I should give potassium.
Potassium and bicarb already. Other than bicarb and potassium, what else? One chance.
One chance.
So this girl has nephrocalcinosis. So you have to give thiazide as well. So unfortunately, minus 10 there. This is the buzzer round basically. So no worries. This was a bit confusing question. So look at the question first completely and then go ahead from that. Next question, open to buzzer. Fourth question, 3-month-old girl with seizures. Calcium is 6.4. Phosphorus is high. PTH is high. Creatinine is normal. So hypocalcemia, hyperphosphatemia. I think Dr. Savar has already come up. Yeah. What will you do? Yeah, you can speak up. You can speak up, Dr. Savar.
Vitamin D level.
Vitamin D level, because this looks like pseudo-hypoparathyroidism, but this could be a transient resistance to PTH in this setting. So absolutely right. 10 marks to Dr. Savar. So now we have got only 2 more questions to go. What is the current score? So Dr. Savar and is at 65. Dr. Azad is at 55. 45 was here, no? 55. 55. Dr. Shubha at 10. Dr. Jaya at 15. And Dr. Rajiv at 20. So a very tough fight between Dr. Savar and Dr. Azad. So both of you should go for these 2 questions, which will decide about who is going to win this quiz. So next one, I have already reset it. Now we will go to the 29th question, which is 1-month-old girl with lethargy, hyponatremia, hyperkalemia, normal genital appearance, high cortisol, normal 17 OHP, high renin, high eldo. Next step to achieve a diagnosis. Dr. Savar, I think Dr. Savar is very quick. Fastest finger first.
Pseudo hypoaldosteronism.
So test. Which test will you do?
Aldosterone level?
It's already high.
So he answered wrong.
No. I'll just give him one chance. You have to give the right answer. Which test? Next test.
Genetic test.
minus 10. We were talking about transient pseudohypoaldosteronism. So you should actually do an ultrasound in a urine routine microscopy before you go for a test. So again, now this has become a very, very tight situation. So both are tied, I believe now. So whoever answers this correctly will win. So be
this
careful.
was not,
so,
sir, this was a correct answer, sir. This is not, I mean, okay, it's fine.
Yeah, so definitely if you have features of pseudohypoaldosteronism, you should get an ultrasound done before you go ahead with a genetic diagnosis. So that will be the way forward, I would say. That's pretty much based upon the standard textbooks as well. So that's the recommendations from me. The final question would be, I'm resetting it again. And the final question is, 10-year-old boy with head trauma and seizures, there is hyponatremia, creatinine is 0.8, urinary sodium is 80, uric acid is 1.8. Dr. Savar, again, if you answer correctly, you are the winner.
Cerebral salt wasting syndrome.
So again, so here uric acid is on the lower side.
But uric sodium is very, very high.
Yes, SIADH, you can rarely have that high level, but in cerebral salt wasting, uric acid will always be high. Uric acid being low means that you are a hypervolemic state, and cerebral salt wasting is a hypovolemic state. So anyway, this was these are two very confusing questions, but so, but I think you've done, this was very, very toughly fought quiz, and it was more of an act of omission than act of commission, which probably, if you had not answered, you would have won the quiz. So that is the way. So I think, yes, as they say that girte hain shahsawar hi maidane jang mein. So I think you are answering questions even though you are on a winning speed. So I think that's a very good spirit of quizzing. So I think that is what is appreciated. And those two questions are a bit tough, so definitely. But I think we'll get the final scores, Dr. Vibha.
So I win.
So this was a very, very toughly fought quiz. So Dr. Savar is at second spot, 45. And he was actually just winning 2 questions before. So 2 questions made a bit of a difference. Dr. Azad is at number 2. Then we have got Dr. Rajiv, Dr. Jaya, and Dr. Shubha. So I think 3 cheers for Dr. Savar. Definitely, he was the star performer throughout. And it's like in the last you have missed a catch or something, and then the match goes out of the hand. That sort of a scenario.
The last answer was not correct, sir.
And Dr. Azad, by having a slightly slow finger, actually it was quite helpful in that regard. So I think we will close that. Before that, we'll have feedback from all of you. So first of all, Dr. Jaya. So Dr. Jaya, you're muted. Dr. Jaya?
Yes, sir.
Yeah, so your feedback?
So it was a very good experience.
Okay, yeah. So I think it was that some of the questions were tough, but that's the way it will be. Dr. Shubha?
Yeah, wonderful experience, sir. For the first time, I have participated in any quiz like this.
Yes, thank you. Dr. Rajiv?
It is a great experience, and the questions was very good, and it was greatly framed, and I am very much privileged to interact with you, sir. Thank you.
And Dr. Samvar, I'm sure it was just a last-minute slip, but
it's hardly an issue, sir. Heartiest congratulations to first Dr. Saddam. He has done wonderfully well, and I enjoyed the quiz thoroughly. The only thing is for endocrine questions, 15 seconds is slightly less time when you have to think on your feet all the time.
So I think next time we'll keep longer. I think that is a good.
But it was a wonderful experience. I prepared very hard for the quiz, and I'm very happy.
You did very well. You did very well, sir. And it was very appreciated by everybody here. Again, a big round of applause. And it was just a whisker, and that sometimes you miss on one point, and that's the whole thing. So very, very highly appreciated, sir. At this stage, your dedication is really encouraging for academics. Dr. Azad?
Really, I enjoyed it, and thank you very much for all of you. Congratulations for all.
Thank you. So I think this will bring us to the end of the basic quiz. We'll now move forward towards the advanced quiz. And I'll request all the participants of the advanced quiz to kindly switch on their videos and the basic quiz, please switch off their videos and the mic in that regards. So we had a very interesting basic quiz. Now we are going to the next level of the advanced quiz. And this is going to cover a lot of these topics in that perspective. And we will discuss from that. Again, there will be a lot of quiz questions which will be there. And before we start, we will have a quick introduction of the various participants for this program. We are already joined in by Dr. Arun. So Dr. Arun, we'll start with you.
Good evening, sir. I'm Dr. Arun. I'm doing my DM pediatric endocrinology at PGI Chandigarh.
And Dr. Arun and Dr. Savar were part of the last program as well, last quiz as well. We've got Dr. Aniket. Dr. Aniket is a pediatric endocrinologist practicing in Sangli. So Dr. Aniket.
Good evening, sir. I was very happy to be part of this program, and this is very good learning experience, and that's why I have participated in this.
Thanks, Dr. Aniket. Dr. Manoj Reddy.
Good evening, sir. Currently, I'm doing my DNB final year endocrinology at Yashoda Hospital, Secunderabad. I'm very glad to be on this platform, sir.
We've got Dr. Reshma from IMS BHU. Dr. Reshma.
Good evening, sir. I'm doing my DM endocrinology at IMS BHU.
Welcome. Dr. Sumaya.
Good evening, sir. I'm Dr. Sumaya. I'm doing my DM endocrinology at Osmania Medical College, Hyderabad, sir. Feel privileged to be part of the quiz, sir. Thank you.
Thank you. And we will also have the other person to join would be Dr. Guru Prasad, who is actually part of the on-site training here. So he would be joining, I think, any point. Dr. Guru Prasad, just follow it with him. So this is going to be an interesting quiz. Again, same format. We'll have 4 rounds which will be there, and the 5th will be on buzzer. So as we see buzzer, you have to be a bit careful because that's the major sort of area in which sometimes it can really change. The quiz can change in the buzzer round. And this is going to be advanced level. So again, we'll give more time. So if you want more time, you can think of it, but don't answer in a hurry because then we won't have a choice in that regard. So we've got 6 participants there. Dr. Arun Josh, Dr. Reshma, Dr. Aniket, Dr. Guru Prasad, Dr. Manoj, and Dr. Somaya. So by the time Dr. Guru Prasad joins in, we will start off the quiz and we will run in a sequence of Dr. Manoj, followed by Dr. Aniket, followed by Dr. Reshma, Dr. Somaya, and Dr. Arun George. And then finally, we have got Dr. Guru Prasad, who has also joined in the quiz in that regard. So the rules are and the prices are: the first prize is a subscription to the advanced pediatric endocrine course. The second prize is a subscription to the basic pediatric endocrine course. And then we have all the finalists will already get a complimentary subscription for the adolescent endocrinology along with the mobile application, which is there. We will have 4 direct and 1 buzzer round, 10 marks for direct and 5 for pass, 15 seconds to answer. As Dr. Samar was saying, we may give a bit more time, so don't hurry up, but think properly. And again, quiz master's decision is final, so we won't take any other references. We'll just decide because we don't have that much time to discuss as well. So we'll start off with the first round. This will be the spot the diagnosis round. And the first question will go to Dr. Manoj, and then we'll go into this sequence, and the second round will go in the opposite sequence. So Dr. Manoj, your question is 7-day-old neonate with irritability. He had hypercalcemia and phosphorus was low. PTH level was high. So he was initially managed with hydration and diuretics, and the treating team thought that we should go for surgery. Now, over time, over the next few weeks, he had a milder form of hypercalcemia, which basically improved over time. And so somehow from severe hypercalcemia, this child went up to a milder hypercalcemia without any surgery. Now, what do you think would be the explanation of this case? So it's a bit of a thought process you think about it. Yeah.
So maybe calcium sensing receptor defect causing familial hypocalciuric hypercalcemia.
Yes. So this is a homozygous or a heterozygous?
Sir, it's a homozygous mutation. So he improved with the hydration. Sir. So usually they will be asymptomatic. So they improve with the hydration.
No, so what I'm saying that this, if you're talking about homozygous, they usually are very severe. They don't improve at all. They would need surgery usually. So this case looked like a surgical case, but then improved. Even after hydration, he became normal. So they
maybe a carrier.
So I'll go for the next person to see if we have a better answer. Dr. Reshma.
Sir, actually, this child has inherited a CSR defect from the father. So he sensed his mother's calcium as low, and that is why he had a transient hypercalcemia.
That's a perfect answer I was looking at, because normally if we talk about homozygous forms, it will be very, very severe. And otherwise, you will have a problem which will happen from that perspective, and there will be a problem in that regards. So that was the first question which was there. So 5 marks to Dr. Reshma for the pass in that regards. Now the next question is directly, so this was a paternal calcium sensing receptor defect. The child is sensing mother's calcium, which is normal as low, and then it causes hypercalcemia, which improves. Now second question is directly to Dr. Reshma. The question is 9-year-old boy with short stature, very short, minus 3.4 SDS. Normal screening investigations, low growth hormone, normal MRI initially. He had a good response to GH. So this is a very early onset GHD. We're looking mostly like a congenital growth hormone deficiency. On follow-up, initially he did not have deficiencies of other hormones, ACTH and TSH, but later on they developed. So people thought this could be a new tumor or something. So MRI was normal. What is the most likely cause? So isolated GHD progressing into a multiple pituitary hormone deficiency.
So this can be a genetic defect like PROP1 mutation, which after GH, ACTH and TSH later on develops.
Okay. Anybody else, if they give a better answer, I'll take it. Otherwise, I'll give it to you. So
PIT
Dr. Somaya.
PROP, sir. PIT or PROP. POF1 or...
I get your point. I get your point. But there is a more specific answer also, option which I'm looking at. If we don't get it, we'll give you the points. Dr. Somaya, do you have any better explanation on that? You're muted. You're muted.
POF1, sir.
POF1. Okay. Dr. Aniket?
Yeah, I think it is POU1, F1 or earlier markers rather than PROP1, because PROP1 generally has very less chances of ACTH deficiency.
Okay. Dr. Arun?
It's probably PROP1, but the secondary, the defects of ACTH and TSH could be because of the mass effect, because of a mass lesion which develops later.
Okay, but MRI was normal. So anyway, yeah, Dr. Guru Prasad, any alternate answers you want to have?
No, sir. PROP1, I feel.
Okay, yeah. And finally, Dr. Reddy?
No, sir. No.
Okay. So actually what I was looking at, PROP1 is of course possible that you can have evolving deficiencies, but one condition which specifically presents like this is a scenario of autosomal dominant form of GHD in which the splicing defect is there. And because of that splicing defects, first you have isolated GHD which develops into a MPHD. But I agree, PROP1 can also cause that. So we'll give 10 marks to Dr. Reshma there. So the next question is to Dr. I think the sequence is Somaya. So Dr. Somaya, your next question is 3-year-old boy with short stature, very short, basal growth hormone is 24, IGF-1 is low, had a normal birth weight. There was no increase in IGF-1 post-GH. So I'm asking for which biochemical test will give you a genetic diagnosis. You're doing a biochemical test which is giving you a diagnosis.
So this looks like Laron syndrome, growth hormone resistance. So IGF-1 generation test can be done.
No, we have done that already. So IGF-1 generation test is already there. This is growth hormone insensitivity. If we did a biochemical test which gave you a diagnosis that this is the genetic defect. So this defect could be at multiple levels, growth hormone receptor, IGF-1, whatever. So this single test gave you a diagnosis. So I want that specific test.
IGF-BP3.
No, we'll go forward. We'll go to Dr. Aniket.
ALS?
ALS, no. Dr. Arun?
Growth hormone antibody to the growth hormone receptor.
No. Dr. Guru Prasad?
No, sir. Pass.
And Dr. Reddy?
No, sir. Pass.
Dr. Reshma?
Pass.
Okay, so this was a trick question actually. This is a growth hormone binding protein. So growth hormone binding protein, if there is a defect, that is an extracellular domain of the growth hormone receptor. So that's a very specific, if GHBP level is low, you will get the diagnosis. So that will, no one will get the answer on that one. Correct answer, it was a bit tricky. So GHBP would be the one which is significant. The next question is to Dr. Aniket. And Dr. Aniket, your question is, a 2-week-old boy with micropenis and hypoglycemia, cortisol is low, sodium is low, potassium is marginally high, ACTH is high, and you can see the picture. You have to focus on one particular part, but I will not go into that. Which routine lab test will give you the diagnosis? So hypoglycemia, hyponatremia, low cortisol, high ACTH. So primary adrenal insufficiency. This clinical picture is giving you a clue, and you want to do a simple test. You'll get the result in 1 hour and you will know the diagnosis.
For whom to answer, sir?
No, Dr. Aniket. Dr. Aniket. Dr. Aniket?
Ketone.
Ketone levels are will not give you the diagnosis. So we will go ahead with the second one. This is a ketotic hypoglycemia anyway. So the next person there would be Dr. Arun. Yeah.
So I would do a lipid profile.
Yes.
For Smith-Lemli Opitz syndrome.
So what are you finding here? Although it's not, he's already on a tube or something, but there is a specific feature. There is already micropenis, which is there. There is also an upturn near, which is there, which is very characteristic of that. So anyway, hyponatremia with, you have to think of a SLO. So correct answer there. So 5 points to Dr. Arun, that is there. The next question is to Dr. Guru Prasad. Direct question. So next question is to Dr. Arun, sorry. So next question directly to Dr. Arun. 10-day-old child with hypoglycemia. GIR is 14, ketone is 0.2, insulin is 2.4, detectable insulin, non-ketotic, no response to diazoxide. Somebody ordered a genetic test. Which of the genetic tests suggest a focal form of hyperinsulinism?
Focal form will be an autosomal recessive mutation of the
recessive or dominant, or coming from which?
This will be a autosomal recessive one. However, it will be not in the
so this is a hyperinsulinism. The question is, which form suggests a focal hyperinsulinism? Final answer, Dr. Arun?
It will be a autosomal recessive, either ABC potassium channel mutation, but affecting
okay,
the
we'll take the second one. Dr. Guru Prasad?
So it is autosomal recessive from the paternal inheritance.
Paternal inheritance, so autosomal recessive. You are right. Paternally inherited defects are suggestive of a focal form of hyperinsulinism. So you do a rapid test for the potassium channel defect. If it is coming from the father, it suggests that you have there's a focal form. So I think 5 marks to Dr. Guru Prasad. It will be autosomal dominant, but the paternal is coming from paternal has to be autosomal dominant. If you have a recessive, this will be a diffuse disease usually. Yeah, so then you will go for dopapet. So the answer, I was looking for a paternal defect. So he was more specific, I would say. So I'll give 5 marks to that. So I think we'll go to the next question to Dr. Guru Prasad. Direct question to you. I think this is the final question of this round. 6-year-old girl with obesity with night blindness. And this is the picture. What is the mode of inheritance of this disease?
So this is Lawrence Moon Barrett-Biedl syndrome with polydactyly.
Yeah. Mode of inheritance. So there will be no marks for the diagnosis because that's very evident.
Yeah. So this is autosomal recessive.
Okay, no. Dr. Manoj?
Autosomal dominant, sir.
Dr. Aniket?
Sir, excellent.
So I think all sort of inheritance have been gone. So Dr. Arun and Dr. Reshma?
Genomic imprinting, sir. Bardet-Biedl is an imprinting disorder.
Dr. Arun George? So I think we have exhausted pretty much
Ciliopathy. Sir, ciliopathy.
Yeah, it is a ciliopathy, but what is the mode of inheritance?
Somatic.
Dr. Somaya, final answer?
Sporadic.
So I think the only one which was not mentioned is a oligogenic inheritance. So this is a specific case of oligogenic inheritance in which many genes combine to give a picture. So Kalaman, some of these hypogonadotropic hypogonadism, and these ones are the oligogenic inheritance. So this was a trick question there, but I think it was a tough one as well. So what is the score at the end of round 1, Dr. Vibha? We have got Dr. Arun George at 5, Dr. Reshma at 15, Dr. Guru Prasad at 10, and others have to open accounts. So I think big round of applause. This is just the beginning. A lot of questions are going to come. So all of you can do well subsequently. We will have a specific question now for the audience. So this you can use the chat option or the Q&A. So first for the audience who are there across the globe, and then from the local audience, we will ask if nobody answers from there. 14-year-old girl with tall stature. Height is 173. There is arachnodactyly. There is an upward lens dislocation. There is pectus. Which acute emergency is likely in this girl with tall stature and upward lens dislocation? Very specific question. So we'll see. So aortic dissection, Dr. Samar has already mentioned. So I think the quiz people, please don't write the answers. This is more for the audience. We'll see. So aortic dissection, the first answer had come, already people were writing here very quickly. Dr. Kompal Paharia, first answer. So again, that's a right answer. So we already started with the first round. We'll now move forward towards the second round. And the second round is about imaging. So these will all be imaging based. So good that we did not have the class on imaging today. So it would have been unfair for Dr. Guru Prasad. So I think this will be the round and we'll go from the backward. So we'll start with Dr. Guru Prasad right away. I would need the sequence because the sequence is here is a bit different. So we'll start with Dr. Guru Prasad. Your direct question is this. You see this image. You have to tell me what is the most common endocrine manifestation of this disorder. This pituitary imaging, you are seeing something. I want to know what is the most common endocrine manifestation. Of course, you have to tell what are you seeing, but you won't get marks. You may get half marks if nobody else tells us, but you have to tell me what is the most common endocrine manifestation of this disorder.
Is there a germinoma with diabetes insipidus?
No. The next one will go to Dr. Arun. Dr. Arun?
Is it a Rathke cyst with growth hormone deficiency?
No. The next one will be Dr. Aniket.
Is it a midline defect? Septoplastia like?
No. Then we have got Dr. Somaya.
It's an arachnoid cyst.
Yes.
Most common manifestation is precocious puberty.
Absolutely right. I think that's a very good answer. So it's an arachnoid cyst, and you can see the cyst which is located in this area. It's a CSF collection which is there, and this is the most commonly causes precocious puberty. So perfect answer, 5 marks to Dr. Somaya. The next direct question is going to Dr. Arun George. And Dr. Arun, your direct question is again, since this is the imaging round, 14-year-old boy with headache and short stature. This was the MRI picture and a very simple test made the diagnosis. So what is the test which will make the diagnosis in this case? Dr. Arun? Dr. Arun, are you there?
Yes.
So what do you think is there?
There is a supracellular mass.
Okay. So we'll move forward to the second person, Dr. Aniket.
Sir, is it a prolactinoma? Prolactin?
It's not a mass. So I'll give an option to both of you. It's not a mass. It's something else. It is reported as a mass, but it's not a mass. So we can go back to Dr. Arun first then, because I'll give a hint to everybody. People say this is a mass, but this is not a mass.
I would do a thyroid function test because hypothyroidism can have a secondarily have a mass like it.
So this is often labeled as a pituitary mass. This is pituitary hyperplasia. It's a diffuse pituitary hyperplasia. So I think that's a good answer. So 10 marks, Dr. Arun, for that. So that will be 10 marks to Dr. Arun. The next person would be Dr. Aniket, who will be getting this direct question. 8-year-old girl with severe short stature. This is the finding. You have to tell me the finding and also the most common endocrine defect that you see.
Sir, is this an interrupted pituitary stalk with?
Yes, yes. So this is interrupted pituitary stalk. You have hypoplastic anterior pituitary. The posterior pituitary is ectopic. There is no stalk.
Yeah.
Yes, so PSIS. What is the most common endocrine defect?
I think growth hormone deficiency is the most common.
So 10 marks there. So again, the right answer from Dr. Aniket. The next question will go to Dr. Somaya. Your question is this 14-year-old boy with headache. And this is the MRI which is there. Now the endocrinopathy, which will tell you what is the site of the defect. The presence of which endocrine disorder will tell you where is the defect or where is it coming from.
Diabetes insipidus.
Yes.
Supracellular mass, craniopharyngioma.
Yeah, absolutely. This looks like a craniopharyngioma. And if you have a DI in this scenario, that will pretty much give the diagnosis. So very good. So you are excellent in neuroradiology, I would say. So I think 10 marks for Somaya again. The next question will go to Dr. Reshma, a direct question. This is a 12-year-old girl with thyroid nodule. Now, TSH is normal. The image looks a bit blurred. I think it has got a lot of calcification. So it's a multiple calcifications. What is the likely risk of malignancy if you have ultrasound like this? How much percentage? I want broad percentages. Dr. Reshma?
Sir, with microcalcifications, risk of malignancy is less. So I will go for 10%, sir.
These are multiple ones actually. So these are one of the higher end. Okay, we'll get the other numbers first. So we'll go forward to Dr. Reddy. What do you think?
It is looking multiple calcifications along with solid areas more. So malignancy risk is more, maybe around 40%.
40%. We'll go further. We'll take other guesses as well. So the next would be Dr. Guru Prasad.
Sir, the microcalcification, the risk is almost 75 to 90%. Papillary carcinoma.
So it's actually a very, very high risk scenario. There's multiple and foiled areas. So the risk will be very high. So it will be like 79. This is the highest end of risk as far as this is concerned. So correct answer, Dr. Guru Prasad. 5 marks for that on that perspective. So we will move forward. I think the last one to Dr. Reddy directly, the direct question. This is the 6-year-old girl with Cushing syndrome. Low dose dexamethasone suppression test did not suppress. Urinary free cortisol very high. ACTH undetectable. This is the adrenal CT. Now, this is a trick question. Which dynamic test would give you a diagnosis? So first of all, you make the diagnosis. What do you think of? And which dynamic test will have a funny result which will give you the diagnosis? It's a bit tricky, but I think if you think over, you will get the diagnosis.
Sir, it may be macronodular adrenal hyperplasia, and doing HDDST, the cortisol may rise in spite of
paradoxical rise in cortisol. So I think that's a absolutely right answer. So we'll give you the marks on that. So paradoxical rise will be relevant. So 10 marks to Dr. Reddy on that perspective. So while we compile the score, we have got the next set of audience question, which is coming up. 3-year-old boy with polyuria. This is an easy one. Urinary osmolality was low. Sodium was high. After DDAVP, the urinary osmolality increased. Diagnosis established by examination. So what examination finding made the diagnosis? So we'll see if somebody has written the answer. So what finding? LCH has already been mentioned. LCH, seborrhea. So the correct answer is seborrhea by Arjun. So Dr. Arjun will the right answer on that. There are 2 LCH, but I'll take the seborrhea the right answer in that perspective. So this is histiocytosis, seborrhea or rash or whatever will be the scenario. So at the end of round 2, we have got Dr. Arun George, Dr. Reshma, Dr. Sumaya, all at 15 points. And we have got Dr. Aniket, Dr. Guru Prasad, and Dr. Reddy at 10 points. So it's a very, very close net contest. So we've ended 2 rounds. We'll go forward to the 3rd round now. And we will again now go forward from Dr. Reddy to start off with. This is going to be a diagnostic dilemma. So these questions will be about diagnostic dilemmas. So the first question to Dr. Reddy is 6-year-old boy, tendon, xanthelismas were there, xanthomas, very high level of LDL cholesterol, started on statin and ezetimibe. And suddenly the parents complained that he was having syncope and he was having giddiness, syncope, postural hypertension. What is the likely diagnosis and what test will you do to identify the cause? So this is familial hypercholesterolemia.
So LDL receptor defect may be the cause.
No, I'm asking, so this is very obviously, this is a LDL receptor problem. I'm specifically asking the cause of syncope.
Maybe atherosclerotic plaques in carotids can cause.
Okay, anything else? I'll take another, I'll come back to you, but there are other more better explanations which are also there. So we'll come to Dr. Reshma. So a child with familial hypercholesterolemia with syncope. Anything to look at specifically?
Sir, I will, sir, clinical examination, are you meaning, or biochemical test?
Clinical, biochemical, imaging, more of biochemical or imaging, I would say.
Sir, I would like to do a ECG.
Okay, for?
Sir, to see for any rhythm abnormality.
Okay, anyway, so we'll go forward then. Next to Dr. Somaya.
So, transient ischemic attack.
Okay, so again, more like atherosclerosis, but I'm looking for a very specific, there is a specific cause. If not, I'll give it to atherosclerosis because that's an obvious explanation. Dr. Aniket, a child with hypercholesterolemia having syncope?
Sir, 2D echo to see any aortic outlet obstruction? Or...
Yes. So this is very important because aortic stenosis is very, very common in this scenario. So we anyway routinely say that you should do an echo. So in this scenario, you should definitely do an echo. So very perfect answer, Dr. Aniket. 5 marks for the pass from there. Now we will have the next question, which will go to Dr. Reshma. The question is 16-year-old girl with amenorrhea. FT4 is low, TSH is normal, MRI is normal, cortisol is normal. So it was diagnosed as central hypothyroidism. And she was started on thyroxine. After follow-up, 4-6 weeks later, the TSH has gone up. So what is this explanation of somebody who was looking like a central hypothyroidism? Now suddenly you see the TSH has gone up. So what is wrong? What is your likely explanation? Maybe you don't need to think of disease. Something else may also explain this.
So this is probably a laboratory error, sir. Maybe the assay they have used different.
So assay different. Any specific type of laboratory error which can explain this?
So the heterophile antibodies can cause.
So that's a perfect answer for that. So I was looking for heterophile antibodies. That's why you have different answers. You have you found low levels and now the levels are high. So this was actually a lab error which was there. So again, 10 marks to Dr. Reshma at that. The next question will go to Dr. Sumaya. And the question there is, again, 16-year-old girl referred to you as thyrotoxicosis. FT4 is very high. TSH is very low. There are no clinical features, no goiter, no tachycardia, no tremor. Now, the treating physician said that there seems to be a drug which has caused this result, and he was right. So which drug can cause this sort of a bizarre thyroid profile?
Sir, apart from levothyroxine, sir.
Yeah, so in levothyroxine, you will have clinical features anyway for thyrotoxicosis. Yeah.
Anti-epileptic, sir.
Anti-epileptics. We'll go to the next person, Dr. Aniket.
Is it amiodarone can lead to such picture?
So I think all of them will have clinical features. What I'm saying is that this child has no clinical features. And so there is a biochemical error. You can say there's a lab error, of course. So which drug is causing this? So we'll move forward to Dr. George, Dr. Arun. Which drug caused this?
Valproate.
No, we'll go quickly. Dr. Guru Prasad.
So heparin?
Heparin will not cause this picture. You can have a high FT4, but that's a different thing altogether. Then we will go to Dr. Manoj.
Sir, biotin.
Biotin. So this is a perfect answer I was looking for. This is a biotin which can cause, because it's a biotin related product, and biotin can cause this biochemical thyrotoxicosis, which is not there from that regard. So this again, the answer is biotin. So there will be 5 marks to Dr. Manoj. Now we will move forward to the next question, will be to Dr. Aniket directly. Dr. Aniket, your question is 16-year-old girl with galactorrhea. Prolactin was reported at 16. She developed headache and vomiting. Somebody did an MRI, it showed a large adenoma. After dilution, sample was 1000. So we know the answer. This is a case of hook effect in which you have got a very high level of prolactin. All you have to say is, tell me 2 more hormones which are affected by a hook effect. So we are continuing this lab errors. So 2 more hormones other than the prolactin which are affected with hook effect. Dr. Aniket?
Yes, sir. 2 more hormones. Is it TSH can have this problem?
And so I would specifically want to have 2 because
okay, yes.
So Dr. Arun? Dr. Arun?
One is TSH and other one testosterone.
No. Dr. Guru Prasad?
ACTH, sir.
ACTH, no. Dr. Manoj?
Calcitonin.
Calcitonin and TSH. Anything else? If you add 1 more, I'll give you full marks. Otherwise, because TSH was already there.
No, sir. ACTH I also wanted to add, but
okay.
As I said, no.
Yeah. So anybody else would like to add? Dr. Reshma? So TSH and calcitonin. So I think we'll give...
So,
gonadotropins.
No. Dr. Sumaya?
AMH, sir?
No. So generally, those tumor markers, so all these tumor markers like HCG, those levels which go very, very high will cause this. So HCG, TSH and calcitonin. So Dr. Aniket gave TSH and Dr. Manoj gave calcitonin. So we'll give half marks to them. 5 marks, because it was a tough question. So 5 marks each to both of them. So now we have a direct question for Dr. Arun. So Dr. Arun, your question is, 16-year-old girl with hirsutism. She had amenorrhea for 3 months. There was no obesity or galactorrhea. Testosterone level was high. Her 17-OHP was slightly elevated, but her ACTH level was normal. So there was a falsely positive 17-OHP level. So the question again, think of falsely positive 17-OHP level. It is an amenorrheic girl. Which test should have been done which could have avoided this misdiagnosis? Dr.
Arun. Like elevated progesterone can cause a falsely elevated 17-OHP.
Yes. So this is a very, very right answer. So basically, usually we want to do 17-OHP in the follicular phase. But if you do in somebody who is amenorrheic, you don't know whether they are going to ovulate or not, you do a progesterone. So the right answer is progesterone. Absolutely right. So 10 marks will go to Dr. Arun for that. The last question in this one would be going to Dr. Guru Prasad. And your question would basically be, A 15-year-old girl with obesity, there is no clinical features of Cushing syndrome. Somebody did a overnight suppression, which was found to be non-suppressed. So you had diagnosed as Cushing syndrome. Urine-free cortisol was normal because you doubted it to be Cushing syndrome. Which drug that the child could have been taking could have caused this clinical picture? So which drug would have caused a falsely positive ONDST while UFC is negative?
Oral contraceptive drugs, sir.
Oral contraceptive drugs would basically cause what? You will have a high
Increases
level
the cortical CBG, cortical blinding globulin, and hence it will increase the cortisol.
So we will take the answer for that 10. So OCPs, or if you are somebody is on phenytoin or any enzyme stimulating drugs also, you will have this false negative, false positive overnight dexamethasone suppression. So I think this is the quiz. So now, while we compile the question, we'll have the audience question. And again, you can write on the Q&A. The question is, 14-year-old boy with gynecomastia. You have got stage 2 breast. Testicular volume is normal. Pubic hair is stage 3. LH, FSH and testosterone is normal. Prolactin is 120. MRI is normal. So again, we are continuing with the lab test. So what would you do in this scenario? So a child who has gynecomastia, normal LH, FSH, testosterone, prolactin is high. MRI is normal. So people are talking about prolactin in dilution. So MRI is, prolactin is already high. So by diluting, it won't help out. Anything else? Audience here? No. So you have got a falsely elevated prolactin. What will you do? No? Manoj?
Macroprolactin.
So this is a macroprolactin. And of course, you will need to do a pegylation study. So the MRI is normal. So this is not a prolactinoma. It's basically because of pegylated. So Dr. Rashi has given the right answer. Dr. Rashi Agarwal from Amrita Institute has given the right answer. So this was a very interesting third round. Before we head towards the final round, let's go to the, again, it's a very neck-to-neck going on. 25 marks each for Dr. Arun and Dr. Reshma. 20 each for Dr. Aniket, Dr. Guru Prasad and Dr. Manoj, and 15 to Dr. Sumaya. So it's a very neck-to-neck fight going on. So let's see what happens in the fourth round before we go ahead for the buzzer on that. So the fourth round is therapeutic dilemma. So this is about questions. What sort of treatment should be given and what should not be given? So we will again go in a reverse order. Dr. Guru Prasad, this will be your direct question. Your question is, 12-year-old girl with hyperglycemia, sugar is 220, there is HbA1c is high, there is developmental delay, deafness, and recurrent stroke. Which drug you should not use? I think this is an easy question. Dr. Guru Prasad? 12-year-old girl with hyperglycemia, multiple things happening, developmental delay, deafness, stroke. Which drug should not be taken? So your answer, Dr. Guru Prasad?
Pass, sir.
Pass. Okay, so we will go back to Dr. Arun.
Diagnosis DENT syndrome and drug contraindicated would be
so we'll go forward.
Sulfonylureas.
So diagnosis is wrong. So we'll go forward. Aniket, Dr. Aniket?
Yes, sir. Probably this is MELAS and metformin should be avoided.
So I think that's a perfect answer. This is a mitochondrial form of diabetes and metformin should be contraindicated. So 5 marks directly to Dr. Aniket. The next question is directly to Dr. Arun George. And Dr. Arun, your question is 17-year-old girl with delayed puberty. Now listen carefully. It's a bit of a tricky question at the end. Stage 1 breast development, stage 1 pubic hair. So delayed puberty, no breast, no pubic hair, normal height, hypertension, and there is a high FSH. There is no palpable gonad. Now the question is, what is the most effective therapy for her hypertension? So there is hypertension with delayed puberty, most effective therapy for hypertension.
So this child has like high FSH, probably Turner syndrome. So most effective therapy would be correction of the coarctation.
Okay, we will move a bit forward. Let's see what other people are saying.
Coarctoplasty.
Dr. Aniket?
Yes, sir. I think this is 17 alpha hydroxylase deficiency of CH.
Yeah.
And so replacement of cortisol, CH.
Absolutely. So this was a trick question. The severity of hypertension is too much. Height is also 154. So we tried to keep Turner's as less likely. So this was 17 hydroxylase. And then hydrocort will be the best option. So I think, again, good. Big round of applause to Dr. Aniket. 5 marks for pass. Now you have a direct question, Dr. Aniket, is coming up for you. Your direct question is 4-week-old girl with refractory hypoglycemia. Ketones are negative. Insulin is high. No response to diazoxide. Dopa PET did not show a focal lesion. Which immunomodulator has been used in this scenario? So I think this is a straightforward one if you know it here.
Yeah, sirolimus.
Sirolimus. So absolutely right. So 10 marks to Dr. Aniket. So Dr. Aniket had had this late surge. So he's having this log overs going on now. So we'll move forward. Next would be to Dr. Sumaya. And Dr. Sumaya, your direct question is 2-week-old girl with failure to thrive. Blood sugar is 420. No ketosis. Birth weight was normal. There were ear creases. And then at 2 months, this diabetes went off. Now this girl comes back to you again at 13 years with again diabetes. So what is the effective treatment in this scenario? So neonatal diabetes, resolved, recurrence. Now what do you treat? Dr. Sumaya?
This is probably a Beckwith treatment. No, okay. Metformin, sir.
No. So we will go forward. Dr. Reshma?
So this was a transient diabetes mellitus involving the ZAG or PLAG. So, sir, here sulfonylureas we will give a try.
Absolutely. Very good answer. This is a transient diabetes. And this ear creases is not because of Beckwith treatment, but because of other imprinting disorders. And then recurrence is treated via this sulfonylurea. Very good response. So again, 5 marks to Dr. Reshma. Now we'll go to the direct question, which is there for Dr. Reshma. 6-week-old girl with failure to thrive. Sodium is 120, potassium is 6.8, hyponatremia, hyperkalemia, normal 17 OHP, high renin, high aldosterone, ultrasound normal. So this looks like a pseudo-hypoaldosteronism. I think diagnosis is very easy. The next part is a bit confusing. Which antibiotic has been used? Some people still use it as a treatment for this condition. So, which antibiotic has been used?
It's a blind guess, sir. Aminoglycoside.
No. We'll go forward to then Dr. Reddy. So it's a tough one. If you know that's that sort of a thing here.
Trimetrin.
Trimetrin, no. Dr. Guru Prasad?
Is it trimethoprim? Sulfamethoxazole?
You are closer, but no, not yet. Then we have got Dr. Arun.
Just a blind guess. Penicillin.
Okay, we'll come back and see if that will be awarded or not. Dr. Aniket?
Is it nitrofurantoin?
No. And now I think we'll go to Dr. Sumaya. I think this was
chloramphenicol.
No.
Chloramphenicol.
We got pretty much all the antibiotics done. So this is an interesting scenario. Carbenoxolone is basically being used wherein you will have the conversion. It will have a 11 beta HSD inhibitor, which will inhibit 11 beta HSD, and this cortisol will then start acting on the mineralocorticoid receptor. So you're doing the opposite of AME. So this is, I won't give the answer to that. So this is the scenario, but some people use it still. The treatment of choice is high-dose fludrocortisone that we use along with sodium chloride and 3% saline. So I think the last question, which is in this round, will go to Dr. Manoj. 14-year-old boy with bipolar disorder on lithium and SSRI, polyuria dehydration, serum sodium is high, urinary osmolality is low, so this is DI, no AVP response. Which is the treatment of choice? And I want a specific one drug only.
It's a nephrogenic DI, sir. Thiazide diuretic, hydrochlorothiazide can be given.
Okay, let's go see if we have a better option for this particular condition. Dr. Guru Prasad?
Sir, lithium induced is always amiloride should be used. It's a drug of choice.
Yes, so for lithium, it's the amiloride. So generally for NDI, we talk about thiazide, but for this particular condition, it is the amiloride which is there. So 5 marks to Dr. Guru Prasad. So I think this was a very interesting round, and we will compile the score. Meanwhile, we have got the final audience question which is coming in. The question is, 2-week preterm neonate has hypercalcemia, phosphorus is 1.8, PTH is low, vitamin D is low, and calcitriol is high. What will be the correct therapeutic strategy to prevent this hypercalcemia from happening? Let's see if we have any Q&A answers coming in. Fat necrosis, no, this was a different scenario. So you have got a 2-week preterm neonate. I'll say he's on TPN, and you're getting this picture. So anybody from here? So phosphorus is low. This low phosphorus is causing 1-alpha hydroxylase and hypercalcemia. So this is what we are looking at. Magnesium, IV calcitriol, phosphate. Dr. Kompal. So I think Dr. Kompal is the maximum scores that she is giving a very good answer from there. So this was the round. Direct rounds are over now. Dr. Aniket had a late surge of 40 marks. So he's really going up in terms of the lead, but it's very narrow. Dr. Reshma is at 30. Dr. Arun George and Dr. Guru Prasad are at 25. Dr. Manoj is at 20. And Dr. Sumaya is 15. So all of them are in a reachable range. And we saw what can happen if you do too much also, you may lose. If you do too little also, you can use. So it's a bit of a problem issue in terms of the buzzer. So before we go ahead with the buzzer, I think we'll try on the chat again. So I will write N, and then all of you try to write Y and see whether it's coming or not. So we have got from Dr. Reddy, Dr. Reshma, Dr. Sumaya, Dr. Arun, Dr. Aniket and Dr. Guru Prasad. So we've got from Dr. Aniket. Dr. Guru Prasad, you're not able to write?
No, sir.
What happens? What is? So I think our team will be there to help you out on that.
So is there negative marking here in this buzzer?
Yes, yes. So I'll come back to the buzzer of what is exactly the scores will be. So yeah, so I'll just put N once, try again, and then we'll explain the rules.
Redo?
Yeah, redo, yeah. So Dr. Sumaya, we have got Dr. Arun, Dr. Reshma, Dr. Manoj, Dr. Guru Prasad. Okay. So I think that's
but
there.
It's
so
and panels. What? It's not coming in mine. It's not coming in mine. It's okay.
Okay. So we have got from everybody. So now we will go on the buzzer round. The chat will be reset after every question. I'll write N and then you have to write Y. The first one to write Y will immediately be asked the question. We'll stop there. There will be no pass, no time to discuss. So think before. Plus 10 for a correct and minus 10 for the wrong answer. So be careful. The total difference is 25 marks. So lowest can become the highest also here if you answer the 6 questions correctly. So I'm resetting it now. And we have the first question coming on in this scenario. The first question is 12-year-old boy with rickets. And this is a picture. You have got low phosphorus, no metabolic acidosis. Dr. Sumaya has already answered. What is the advantage of novel therapy? You have to tell me the advantage of the new therapy. First of all, what is the new therapy and what is its advantage? Dr. Sumaya?
Sir, can you hear me, sir?
Yeah, now
yes, sir. It's new. This is hypophosphatemic rickets.
Yeah,
so the new therapy is burosumab, which is a monoclonal antibody against FGF23.
Yeah. And the advantage?
So it directly acts at the level of the FGF23. So
what is the adverse effect which doesn't happen, which we had with conventional therapy? Effect on which organ?
Renal.
Renal. So nephrocalcinosis will not happen, less hypercalciuria. So we'll give you 10 points on that. So this was a perfectly right answer by Dr. Somaya. So 10 marks. This is hypophosphatemic ricket, burosumab, and you get less hypercalciuria. I am resetting again. The next question is 5-year-old girl with lipemic serum, very high triglyceride. Dr. Arun George, gene therapy. Which therapy? Name the therapy. You have to give me the specific name of the therapy.
This is familial hypertriglyceridemia. So the
which can cure the disease.
Lipid can be done.
No, that will not cure the disease. So the answer I was looking for was a specific therapy, Glybera. Glybera, which is a treatment which was given for gene therapy. It's a very expensive therapy. So unfortunately, that will not be accepted. So -10 there for Dr. Arun.
Excuse me, sir.
Yeah.
Excuse me, I am unable to type in the chat box. Sir.
Okay, we'll try again. So I'll put N. You write.
They
make it to everyone. To everyone, you have to say. The answer should be to everyone.
Yes, sir. Hosts and panelists.
So, but we are not getting.
I'm not getting that that tab for typing basically.
Okay. So that's a tricky one. Other people, you can try once and see if it's working. So we are getting from Dr. Guru Prasad, Dr. Reshma, Dr. Arun, Dr. Anya. Everybody else is able to do it. So you want to try it again? Yeah, now we are getting it.
Okay, okay, sir. Sure.
Now
thank you.
Yeah. So we are reset it again. There are 4 more questions to go. This one, I think, may be one which is easy. Which treatment has recently been approved? So the first one to go on this one is Dr. Aniket.
Sir, this is
the condition is?
Condition is again the hypophosphatemic rickets.
Hypophosphatemic rickets, okay. I think we'll now, because there's no pass here, we will ask the audience here. What do you think the diagnosis is? Hypochondroplasia, achondroplasia, and the treatment is vosoritide. So that will be -10 then for Dr. Aniket. So look into the question carefully, I think, before you go ahead. So we now have got only 3 questions, I think, remaining. Vosoritide will be the CNP receptor agonist. Next question, I've reset the button. 13-year-old girl, GHD, advised growth hormone. Now, the question is, which long-acting growth hormone acts to increasing albumin binding, Dr. Somaya?
Sir, Lonapeg somatropin.
Lonapeg, that increases the albumin binding.
Sir, somatrogon.
No, the answer is somapacitan, so -10. So that is there are different mechanisms by which it works. So it will be somapacitan, -10 there. So we'll again reset. Now we have got only 2 questions left. What is the current score? Dr. Vibha?
Dr. Arun George.
So you have not calculated.
No, sir.
50, 30. So we have got Dr. Reshma and Dr. Aniket who are tied at 30. Dr. Guru Prasad is at 25. Dr. Manoj is at 20. Dr. Arun is 15. And Dr. Somaya is 15. So again, it's a very, very tight race. Still, this 15 can take 2 questions and there will be 35. So we can still go for the last ball. 6 can be there. A possibility is there. So I'm going to reset it again. And the last 2 questions. So this question is coming now. 4-year-old boy with rapid growth. Height is there. So we already got the answer. Dr. Reshma has said, now what is the mode of inheritance?
Sir, this is Beckwith-Wiedemann. It is an imprinting disorder.
So I think this time we've got the absolute right imprinting. So we've got 10 marks, Dr. Reshma. So good. So what is the score now?
10 marks, then she was 40 highest.
Yes.
And next is Dr. Aniket, 30. And 25, Dr. Guru Prasad. And Dr. Manoj, 15, Dr. Arun and Dr. Sumaya.
So this question is for Dr. Aniket to take those 10 marks. Otherwise, Dr. Reshma is going to be winning anyway. So this is going to be a very tough fight. Let's see what happens. So we will put it the reset. And the question is this. 3-year-old girl with rapid weight gain. Dr. Aniket has already said. So you give me the answer immediately. So Dr. Aniket. We don't have time to think now.
Leptin, sir.
Leptin. No, you read the whole question now, but the answer is already wrong, so it won't be making a difference. It's a 3-year-old girl with rapid weight gain, fairer compared to the parents, low cortisol, and a low ACT.
Sorry, sir. MC4R.
Yeah. But unfortunately, we don't give up a second choice in this one.
Okay.
So, this was actually, if you had thought, you would have got the answer. MC4R receptor agonist, set melanocyte. But anyway, this was a wonderful effort by Dr. Aniket as well. So we have come to the end. While we compile the score, I think there is one final audience question. Blood sugar of 450 DKA managed with insulin infusion in a newborn child, which clinical finding predicts transient form? We already discussed this, I think, just before that. So which finding? I think we'll see the audience. What are they saying? Set melanocyte already was answered. So it was, the audience are very, very reactive. So Dr. Shruti, umbilical hernia, omphalocele, ear creases, these are all like transient phenomena. So I think this was a wonderful interactive session. And by the time we come to the final scores, we have got Dr. Reshma, who has got the top score of 40. So big round of applause to her. The second position, there is a tie between, second position is to Dr. Guru Prasad, 25. So that's a clear-cut winner. Then there is a tie between Dr. Aniket and Dr. Manoj Reddy. Dr. Aniket lost 20 points actually in the last one. Otherwise, he would have won the quiz. So again, both the quizzes, the person who gave more answers. So again, as I said, if you run, then only you will fall. So that is there's no problem with that. I think that's the right attitude. And we have got Dr. Sumaya and Dr. Arun both with 15. So I think this was a wonderful experience. Before we close, we'll take a feedback from all of you. Dr. Sumaya.
Sir, thank you so much. This was like a great learning experience, sir, especially in pediatric endocrine, to get to know pediatric endocrinology better. So it was really wonderful. Thank you, sir.
Okay. Dr. Manoj?
Yes, sir. I learned a lot regarding pediatric endocrinology from your videos. And today I got an opportunity to learn some more points in pediatric endocrinology. Thank you, sir, for this platform.
Dr. Arun?
It was a very good experience, sir. Learned a lot of new things today from you, sir. As always, your quiz was excellent.
Yes, so quiz is basically meant to encourage knowledge. It's not like a competition because some questions you will know, some questions know, others will not know. So don't worry too much about all that. Dr. Aniket, you were doing very well. And then you got caught at the boundary line, I think.
Yes. Yes. But it was a great learning experience. And it is always a pleasure to interact with you. And this was one of the opportunity which I would never lose to interact with you. So that was very nice.
Thank you, Dr. Aniket. Dr. Guru Prasad?
Sir, as a general physician, you made me to appear for a pediatric endocrinology quiz. So the credit goes to you. And I always call you as an endocrine storyteller. Thank you, sir.
Thank you. And Dr. Reshma, finally?
Thank you so much. Thank you so much, sir. It was a huge learning experience. And I would like to thank Arun. He helped me prepare what all to read. He was telling me. And Santosh, sir, my teacher,
Dr. Santosh is here only. So you can come up and
excited, I am sure, more than me.
So Dr. Santosh is here only. So I think this was a wonderful experience and good to see that a lot of people are getting interested and we had got so much audience participation. Already about 100 people, 86 people have already answered questions. So it was like a huge one. And I'll give a big round of applause to all of you, all the audience who are here since morning as well. And thanks to Dr. Manoj, Dr. Vibha and Dr. Dhwani for being part of this. So we will be closing now. We will be contacting the people who have won the awards and the other people, the finalists, about the prizes and how we will go ahead on that. And also for the audience. So we will mail you on that. So I think we'll close at that point of time.